Hematuria, the RBC more than 5 per microliter in fresh uncentrifuged urine, and we have more than 3 RBC per microliter of centrifuged urine. It is called hematuria. Below that, now you can have a little bit of 1 or 2 RBC. That is not significant. And we know that 1 ml of blood stains 1000 ml of urine red. So looking at the urine red coloration, you can don't be scared of, because good amount of them are due to the food, medications, and other non-hemoglobinuric, non-hematuric red urine. So after you see the hematuria, you see the what are the possible causes in the child. Don't be scared of again. So if in American study, the screening population has shown that 4 to 5% of the school going children of 8 to 12 years old do have a real hematuria, and they did for second time, and it was came out as less than 1%. That means insignificant hematuria. They didn't have long lasting or permanent hematuria. When they screened further, no, they found less than 0.1% who really needs some intervention. So studying Japan and Korea, and you're on that belt, the Hong Kong and others, they have higher incidence of IgA vasculitis and IgA nephropathy. Thereby, they screen the children annually in the school. So they found the good amount of the cases of their diagnosis IgA and mediated disease, hematuria higher than the other parts of the globe. So they suggest do screen and find out these cases early. So when there is hematuria with you have proteinuria, you have significant renal disease. When both of them are in in higher informed amount, suppose proteinuria, non-nephrotic, and even nephrotic, persistent hematuria, persistent second time, third time, every time it is coming as a positive, plenty of RBC. So you take it as significant glomerular disease and should go for the investigation. Other cases may not be significant renal disease, so we can wait and see. And then and of course renal disease who has significant involvement and needs some intervention, they will have ultimately the significant hematuria and significant proteinuria. Until that you can wait, because intervention before this stage you will not give any benefit. It's not needed. So apart from that, you have non-glomerular hematuria like your obstructive uropathy, your dilated system, you have the UTI, polycystic kidney disease, you have Nutcracker syndrome, you have Kakut, you have trauma, you have tumor, and other infective non-infective obstructive disorders. So why you won't go for investigating when child has insignificant hematuria and without any proteinuria or renal impairment and others? Because the diseases like Henoch-Schulin previous, nowadays IgA vasculitis, what it does, it has recurrence and remissions, and the attacks, most of the 80% of the attacks are self-limiting. They do not need any intervention. So why do you investigate? When the disease is severe, you need intervention, you go for the investigating. So and there will have severe presentation. That means significant persistent hematuria and proteinuria, along with it hypertension, azotemia, edema, and other features of complement and other features of the renal injury will be there. So also the case with the viral UTI, exercise-induced hematuria, and hematuric syndrome, who has trivial presentations at the beginning. So in the glomerular disease, apart from the renal histology, which is diagnostic, you have serology. Suppose lupus nephritis, you have C3, C4, ANA, NTDS, DNA. You have C3GP. You have their autoantibody. You have genetics. You have the complement 3, 4, and you have the inciting travel infections. So and good amount of time you have the biopsy, and you have genetics underlying the hematuric disorders. So do those stages don't be jumpy over here, stage wise, and see response is a clinical decision. A clinical sort of injury will decide the next course of action. So red urine maybe your microscopy negative, your maybe your red devisting negative. They are just food, drugs, exercise, fever, etc. Non which needs no intervention. Red urine may be due to your hematuria and proteinuria, a serious sort of illness. And on the other hand, red urine they are both devistic positive and microscopy positive. And the hemolytic if anemia, the suppose hemoglobinuria, myoglobinuria, thalassemia, trauma, etc. They will have the microscopy negative but devistic positive. Then it's the intervention in other way. The your why the RBC is breaking down, CBC, PBF, electrophoresis, and so on and so forth on that line. And the common line, the gravest one, is the devistic positive, microscopy positive. How will you investigate them? Glomerular causes, you do the C3. Then you have an entity like the post-infectious, commonly post-streptococcal and C3GP and other ICMPGN and other MPGN, and shunt nephritis, infective endocarditis, that is infection-related GN, IRGN. On the C3 normal cases, you have IgA vasculitis, IgA nephropathy, Alport syndrome, hemolytic uremic syndrome, and the other hematuric disorders. Brother of the newer addition or the old brother of your Alport, TBMN, thin basement disease, and non-glomerular bleeding, less, no insignificant, not dysmorphic RBC. Dysmorphic means RBC which is distorted while it tries to pass in the narrow glomerulus. To more than 30% dysmorphic RBC, you call it significant dysmorphic RBC. They mean you have glomerular bleeding. While less than 10, it is your non-glomerular bleeding. That is tubular and renal, one parenchymal interstitial inflammation. Here you have UTI, hypercalciuria, you have obstructive urinary. So do urine calcium creatine ratio, ultrasound, culture, your Doppler, and then your other non-contrast CT scan. These are the investigations that you need to do on this side. That means obstructive, cystic disease, and your tumor, and your vascular disease like nutcrackers, others.